Assalamu alaikum, and welcome to the very first episode on the season on the farm. And this is such a special recording for me, as all of these episodes that are going to be played out are recorded in person with people that I've had deep, long, and meaningful conversations with. So today we're going to start with the first episode on psychiatry and the soul. How a psychiatrist navigating America's hospitals is working through his heart and through his soul to serve the patients that are coming from all diverse backgrounds and needing support, needing to be seen and held and be recognized as humans. So today we're hosting Armaan Rowther, and together we're going to have a really deep and meaningful conversation on how's it like to be a psychiatrist in America who's also Muslim and who's also trained in Islamic psychology. Salam alaikum.
Wa alaikum assalam.
It's very lovely to have you here.
The honor and the pleasure is mine. Alhamdulillah.
I've been trying to have this episode recording with Armaan since I started the podcast, actually.
Wow.
And subhanAllah, until we became like sitting here in this room in California, we're like actually able to do it.
That's all you had to do. You had to come all the way to California to find me.
I had to fly 18 hours just to record this episode. So it's really a pleasure to have you. And just so that the listeners know a bit of a context, that this is literally a conversation that we're just having openly without any preparation. So it's going to flow very organically, hopefully. And how would you like to start by introducing yourself, telling us a bit about you?
Sure. Yeah. So my name is Armaan Rowther. I'm a resident physician at a county hospital in Los Angeles called Harbor UCLA. And specifically, I'm a resident in the Department of Psychiatry. So I am just at the start of my third year. So I'm considered one of the senior members of the program. That means I spend a lot of time doing a little bit of everything. So we see inpatients in the Department of Psychiatry. We have our own outpatient panel. But we also spend a lot of time in one of the busiest emergency departments, dedicated psychiatric emergency departments in the country. And so that's what my everyday training experience looks like. It's a mix of all of those things. And before I started residency here, I'm originally from Southern California, but I did all of my graduate training over on the East Coast. So that was a combined MD PhD that I did at Johns Hopkins with a PhD that was specifically focused on public health. So most, MD PhDs, they're doing a lot of basic science research. They're doing a lot of bench work or lab work for their PhDs. But more and more institutions are now recognizing that, public health is an extremely relevant science to combine with medicine, with clinical medicine, and that there's value in having people who can have a foot in each side, especially as research gets more and more specialized,
Yeah.
So even people who you'd think of as doing really clinical research, they maybe have no experience in an actual clinical setting treating a patient. And so the general idea is have people who do a little bit of both. So my PhD was in this small department inside of an enormous school. It was called the Social and Behavioral Interventions program within the Department of International Health over at the Bloomberg School of Public Health. And so I did all that. And it was actually at the tail end of that I first met you, Noura.
I remember. Yeah. I remember when you sent us the picture of your match, I think the residency.
Yeah, that's right.
Yeah.
So I did my first sort of foray into Islamic psychology was during overlapping with my last year of medical school.
Oh, wow.
And since then, we've met at least through 3 different training programs, in Cambridge, in Istanbul, and now here in Pescadero, California. And it's been a journey. I think you'd agree, probably.
Oh, 100%. Yeah.
Yeah, it's been a journey of a lot of trying to integrate things that conventionally get so dichotomized and or isolated as not being able to be done together. For example, um, attention to the psychological dynamics of patients, including mental distress, including mental illness, and the area of spiritual soul development. Right? These are things that
Mm,
commonly get uh, treated as completely separate disciplines. And we are, I think, through the Islamic psychology program, experiencing the difficulty uh, of seeing and witnessing and experiencing how inseparable those things are,
mhm,
but then going back into a world of practice where these are considered, um, on two sides of an inseparable barrier,
mm.
one that you can't cross. And that's, I think, challenging to keep going in and out of those two settings.
And as someone with a hat of a researcher and like a physician, and you've done like a lot of work in settings that are pretty different than this, how's it like for you? Like, not necessarily shift gears, but like, how do you maneuver the differences? Because a lot of the work that we do here is really based on whether experiences or like subjective reporting and like trusting as well a lot of the process. So, I mean, I'm just curious about like your um, doctor, researcher, physician hat.
Yeah, I mean, I think one thing I've come to appreciate is that multimodality, that ability to wear multiple hats, that aspect of being able to integrate these different sciences, that is a heritage of our tradition. In the Islamic tradition, when we look historically, even the most either famous or accomplished physicians, right, in Islamic medicine, they were polymaths. They were, in addition to that, scholars of religion. They were, in addition to that, sometimes chemists, sometimes historians, sometimes linguists. And so they were, I mean, obviously, I think it's hard to recreate that level of capaciousness that they had to be able to cross all those disciplinary lines. But that is us following, I think, in the footsteps of the tradition that we're inheriting
Mm.
as Muslims. The second thing is it's a lot of just sitting with contradictions all the time, and I think that's a
Yeah.
space that I've gotten more and more comfortable with because I've done it in a lot of different arenas. You know, from the outset, I didn't intend to become a doctor. I really, when I was in undergrad, even when I was in high school, my role model was actually my grandfather, who was a diplomat. He was
Oh,
a
there you go. There's the eloquency from.
You're right. It explains something, I think. He was a public servant. He was a member of the Foreign Service for Pakistan.
Mm,
And so he was involved in a lot of work in trying to build bridges, between people, between communities. Um, he himself was somebody who came from a displaced community, post partition. Um, and that was an experience that I think shaped his entire career, is trying to really build bridges
mhm,
and create homes and create a sense of identity in what was otherwise a political and a cultural and a societal mess, which was, post-partition South Asia. And so I really thought of myself as, if I'm going to, be a public servant of doing things similar to that, going into international affairs, doing things like that. But what I found increasingly compelling was the fact that that same drive of trying to empower people, of trying to, uh, I think, help people come out of crises,
mhm,
come out of that type of disruption in their lives with the tools to be even more resilient, even more equipped. Really, that was something that I felt I found the most role models in public health and in medicine,
mm,
because there is a sense of borderlessness in the idea of us attending to people and their health, attending to people and their times of need from the standpoint of a physician.
mm,
And so I found that that was actually very liberating. You no longer have to figure out, whose interests you're advocating for in the whatever negotiating room or in the
Mm,
United Nations committee or whatever it is that you're trying to work in. And there's a sense of I serve humanity as a physician. That is the ethical code that drives everything I do.
mm,
And so that causes a lot of contradictions. It causes you to at times have to, um, for example, serve people that others think aren't worthy of being served.
mm,
Whether that's because they struggle with addiction, whether that's because they've committed a crime, whether that's because they're indigent for reasons that people find ways of attributing to their own um, behaviors,
mhm,
that somehow those people are less worthy of care or less worthy of. And so where I work, at the county hospital, that's primarily the people I work with.
addiction. Mm,
Folks who are really the I would say the most disenfranchised. Either they have no insurance at all, maybe they're undocumented,
mm,
maybe they are on public assistance or dependent on public assistance,
okay.
or they're just too complicated. They have too many comorbidities for uh, private institutions to feel like they can serve them, because they have more conditions that complicate one another than others want to deal with.
I see. So I think I'm gonna like stir this conversation towards that as well. This was such a lovely introduction, to be honest, and I feel like it gives a lot of context of who you are as a person and who you are as a practitioner as well as a psychiatrist. And in the Muslim part of the world where there's a lot of maybe challenges, let's say, or a hard time to accept taking medications. I work with a lot of patients who find a really hard time to accept sometimes that they need like support from meds. And I don't know if you can speak about that, not necessarily advocating or not advocating for it, but like your perception, experience, like thought about this.
Yeah, I think that's a great question, because
Thank you. I thought about it.
it's really at the crux of, I think, a lot of what we struggle with as a community, but also as practitioners. And the reason I say that is because, again, there's like this sense of either medications have a role, or spiritually integrated treatment modalities like Islamic psychology have primacy in people's minds. It's
Mm,
almost a mutual exclusivity.
mm,
Like, if I'm going to talk about medications, then all of a sudden that means that I don't believe that spiritual phenomena contribute to mental distress or physical ailments, right?
uh,
And I think the beauty of the training that we're in, and the training that we have gotten over the years in Islamic psychology, is that I would say one of its most fundamental tenets is that the human being exists ontologically at multiple levels,
mm.
right?
Elaborate on this, please.
Yeah. So I think most models that try to look at human beings holistically, they do so by looking at, oh, these are different levels, like this, the biopsychosocial model. They just try to look at, well, what is the biological level? What's the psychological level? What are the social factors? But in doing so, they're still highly reductionist. They're still trying to analyze each of these as though they are in their own silo, and we just have to address each of them. But that's very different than saying that the human being, as a unified ontological entity, just exists at multiple levels.
Mm,
That we have a physical level, we have a psychological level, but we also have a spiritual reality that underlies all of that. And so when you understand that as indivisible, really, as really being a constant truth, that we are both physical beings, with all the factors that affect us because of that, simultaneously, we are spiritual beings in the midst of a physical experience. It allows us to say that medications can have a role. There can be an understanding of that there are biological factors that contribute to things like depression, that contribute to things like schizophrenia, that contribute to these phenomena that we've studied for many decades to centuries in psychiatry, but that doesn't remove the imperative for me to attend to the soul of the person in front of me.
Mm,
And the fact that I'm going to say that medications has a role doesn't mean that there's no place for me to think about the demoralization of that person in front of me,
mm,
the existential or the spiritual crisis that they're simultaneously experiencing,
mhm.
the trauma or the abuse that they're going through, right? That's all contributing to this. I think we sort of are selective. In some respects, we can see people as having multiple things going on at the same time. But on the other, there's this defensiveness that I think comes about when it comes to psychotropics,
Mm.
where it's like, if I say that this person might benefit from medication, it's as though I'm declaring that the only thing that's going on here is a biological disease.
Oh, I see.
And that's just not true.
Mm.
It's just not the case.
How did we get but, like, how do you think we got here into, like, doing this, like, the dichotomies or, like, either or?
Yeah, yeah.
If this is a full-blown tangent, we don't need to go on it because I like where you're going here, and I also felt interested to ask about, um, when you said, "All right, some people will benefit, and I will be attending to their soul." Um, do you see this with your work, with your patients? Like, how's it like for you in practice?
Yeah, both excellent questions. So, the question of how we got where we are. I I mean, the truth is I don't know how it is that we've arrived in the place that we are. What I do know is that certainly the field of psychiatry, for example, has through its entire history been defined by pretty extreme swings in
Mm,
one direction or another. And that's, I think, just the outcome of when we treat um, any subject of study with a reductionist
mm,
imperative, that I need to figure out what the single explanation is that drives all of this. That's how we arrived at psychoanalytics, that we could say that everything that's going on is explained by the id ego and the superego. It's explained by the um, death drive or the pleasure drive
mm,
or the libido. There's a sense that we're going to come up with this one explanatory principle, and then there was a huge reaction against that, and then we got really focused on behaviorism. Looking at everything as basically conditioning.
mm,
Everything that the human being does is just a matter of reward and punishment and classical conditioning. So we just go through these extremes, and we've gone through these chapters. So on the one hand, I think the modern attitude predisposes us to make this mistake, to feel like we have to decide that this is, uh, you know, all there is to the answer to this question. But the other thing is, I think there's a rational and a reasonable hesitancy that people have um, toward, I think, what has often been uh, the practice of medicine as being pretty aggressive, pretty exclusionary, because there's no question that there's been a ton of advancements that are extraordinarily beneficial for society that come out of the modern enterprise of medicine, whether that's drug development, whether that's the really I think productive and beneficial interventions that have been, let's say, developed. The problem is that many of them have always been delivered as silver bullets
mm,
with this claim that because this came out of our epistemological tradition as modern academics, which is everything has to be an RCT, right?
yeah.
That every other way of understanding or knowing the thing that we're targeting has to be eliminated. That's the only way we can get people to comply with our treatments.
Mm, mm, mm,
And I think you know, that's sort of set us up for the problem we're having.
mm,
You can't, um, I think, try to convince someone
mhm,
to take a medication that you think is beneficial for them by telling them that every aspect of what their family, what their personal experience, what their spiritual tradition, what their heritage, right? has had to say about this human phenomenon that's existed for ages is all invalid.
Mm,
And that's why you should take this medicine that I'm handing you. I mean, that's often, I think, even if that's not the intent of the practitioner,
yeah.
when a psychiatrist prescribes, that's how it's received, I think, by some patients. And so,
Mm.
that creates a lot of resistance naturally.
100%, yeah. And what helps? Like, what helps when we think about patients, and specifically if you think about your patients who have, like, do you notice any difference with patients who rely on some sort of faith in their journey, or like throughout, and they're also getting support from meds or from therapy? Do you notice any difference between them and others who probably don't have this? Not like, not 100% sure about this question, but I'm, because I know it's a bit like researchy.
No, I think it really depends on the relationship of that person
Hmm.
to their spiritual understanding.
Okay.
So for some of my patients, whether they experience psychosis or whether they experience really severe depression to the point of suicidality, or whether they just experience extreme trauma, them having an explanatory system of their place in this world or in this life that gives them an ability to see meaning, even in adversity, to see meaning in the very trials and the challenges that they're experiencing. I think a lot of those patients do much better.
Mm,
A lot of those patients, and I'm not going to cite the literature or go into, what data shows about people's
mm,
level of spirituality and how they do in terms of mental health or resilience or recovery. From my firsthand experience, just on a whatever end that would be with my patients, if they recover from a psychotic episode and they have a way that integrates that experience with their understanding of themselves,
huh.
then I think they've just done much better, in terms of, and again, this doesn't preclude them continuing medications. It's just in understanding this cataclysmic event that they went through in their life.
Mm.
They no longer live their life in fear of becoming psychotic. They live their life with an understanding that that's something that they did go through,
Ah.
and that perhaps these medicines help, prevent the chance of it recurring. But they have this sense of hope. They have this, I think, morale that's provided by
Mhm,
their spiritual anchoring.
mhm.
Okay. Now there's others.
And can
Yeah,
sometimes the psychotic episode be, I'm hoping on recording another episode on this, on psychosis.
sure.
But can sometimes the psychotic episode be mistaken for a spiritual experience? Like, is there some way where, like, there's a line, or are they enmeshed, or?
Yeah, I mean, psychoses can be very different from one another, so it's
Mhm.
hard to generalize that as a topic because, again, these are all, like you mentioned, subjective experiences.
Yeah.
It's one of the greatest challenges of the field of psychiatry is that we rely entirely on a systematic examination of something that I can only understand based on what you tell me
Yeah.
of what you're experiencing.
Wow.
There's nothing I can measure. There's nothing I can do other than listen with as open of a mind and a heart to what you're telling me and try to reach some empathic or understandable sense of what's your inner world look like right now. So that's how psychosis is defined, right? It's by the things that you're going through. And so I think I would really resist categorizing anything where it lumps all of what we call psychosis into one category.
I see.
Um,
I see. Yeah.
because for sure we have aberrant experiences, we have abnormal experiences. Sometimes those come from pretty well studied patterns of psychosis, right? For example, psychotic mania.
Mhm.
You know, that's something where we see that it comes in a pattern with people who have manic depressive or bipolar 2,
Mm.
no, sorry, bipolar 1, um, and it comes with this predictable pattern. There's a sense of treatments that are most effective to it. There's a very strong sense of the biological things that contribute to it emerging.
Hmm.
But that's not what causes psychosis in everyone, right? Not everyone has that pattern. And so I wouldn't lump them all into one category.
I see. I see. How do you integrate this work with your patients? Like when you say like I'm working with not just like their psychological symptoms, also working with them as human beings, as souls, and I'm like this
Yeah.
is something that I'm like you're targeting. Like, so how do you see that in your work? Or like how's it like for you to be coming from this background, from this faith, from this tradition, and you're working with a wide diversity of people? Do you feel like that changed the way you practice medicine since like you started this journey for the past 3 years?
I think starting this journey is what enabled actually everything about um, my, I guess, my sense of self, but also my understanding of, fundamental truths about reality that are rooted in the Islamic tradition to actually influence my day to day sense of what it means to be a physician. Because I think it's really hard for many Muslim physicians to find that balance. I think there are many of us who we go into medicine for very good reasons. We go in with a sense of it being inherently a field of service, a profession where we have a chance to attend to the ill, to have ibadah, to have worship in the everyday act that we do for our job, which is to help sick people.
Mm.
But then we enter the field of medicine. We go through the rigor of medical school. We go through the sort of hoops of all the personal statements, all the standardized exams, and subsequently our clinical training. And all of that includes with it a very subtle, unspoken, but very deeply embedded assumption that the only thing that's relevant is material existence, that everything can be explained by neurotransmitters, by um, cellular processes, by genetic inheritance and genetic uh, aberrations, and that's the only level of reality that exists,
Mm.
and that shapes every part of what the experience in medical school is, even in ways that we don't really attend to very often. So, for example, like a really easy example, um, the way you start your training in medical school in America is often your first patient being a cadaver.
Yeah.
The first thing you do in medical school is anatomy lab.
Oh yeah. 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 Yeah.
And, it's not just, Islamic psychologists who would say maybe there's something problematic about that. Even Arthur Kleinman, who's a very famous psychiatrist and medical anthropologist, and, someone who comments a lot about the culture of medicine really adeptly. He'll point out that that's not universally the case. You go to other countries, and the first thing you do, let's say as a medical student, is you get placed in the home of someone who's disabled and you assist them.
Oh wow.
A living patient who has real deficits, who needs, let's say, in home care or some sort of assistance.
Mm.
Those students who are embarking on the field of this profession, that's their first exposure of what it takes to be in this field. Whereas in America, it's pretty universal that you'll start with either a lecture on, I don't know, some basic science, or for the case in many schools, including where I trained, you start with a dead body. You start with the process of dissecting every
Oh.
sinew and tissue of a cadaver. And that's your first exposure to what it means to be a physician with respect to the skill set that makes you competent. Think about that difference. Think about what long term implications that has for how you understand what you're doing. And I think that's why it's very natural that Muslim physicians sort of develop a double identity.
Right.
Yeah,
Yeah.
you start to very quickly realize that to survive or to thrive or to exist in this space,
Mm.
and then excel, you have to be able to maintain all your, tenets of your faith, but sort of draw a line of the significance of those things, the implications of those things when it comes to the clinic and the hospital, because that's a space of very radical secular materialism.
Mm.
And even if you don't subscribe to it, you're operating within systems that have an unspoken logic based on that. And so it's very morally injurious, I would say, and it's very challenging. When I did started doing Islamic psychology, that was the first time I think that I felt this real opportunity to treat everything that we're talking about as, sometimes we think of and we conceptualize as religious sciences, things like aqidah.
Mm.
But really, that's not like just a religious science, right? That's a fundamental belief about ontology and epistemology and everything that's relevant actually to not just philosophy, but also science,
Yeah.
right? Everything that you do in science is influenced by what your epistemological assumptions are that underline it and that underlie it. So as a result of that, Islamic psychology was the first place where we got to interrogate what are the implications of an Islamic worldview to how you see illness and health and how you actually interface with a patient sitting in the room with you,
Oh, wow. Yeah.
all the way down from so, and those are things that, again, we often think of as not relevant. That's just what you do in Sunday school, or it's what you do in the mosque. And so, fortunately or unfortunately, the setting that I work in, especially when I first started as an intern, it's mostly with patients who are very severely ill. So many patients were still experiencing active symptoms of psychosis,
Mm.
patients whom you would not think are going to be good candidates for what we think of as talk therapy. And the fortunate or sort of hidden, I think, blessing of that was that it immediately allowed me to, I think, implement some of the most fundamental principles of Islamic psychology,
Uh-huh.
which is that it's not all about what I'm going to say to you. It's not about the ways that I can cognitively restructure how you're thinking about your problems, but rather there's something therapeutic and there's something healing in just the state that I arrive in when I come to the side, to the bedside, or to the clinical encounter space, whatever it is, and hold that patient. Hold
Mm.
that patient in the sense of, or hold them within the envelope of my empathy, my concern, my goodwill, and my real, sincere dedication to be with what is with that person in that moment, to witness their suffering, right?
Right. Mm.
To bear witness to it and to help them be able to sit with it and to ultimately, hopefully, transform it. But even just in the first step, so even when I was on the inpatient floors, some of the principles that we learn in Islamic psychology, they're not about the method of how you're going to coach your patient or teach them, but it's just about really the ethics and the virtue of a clinician and how vital that is to the clinical encounter. So being in a state of wudu,
Yeah.
being in a heightened state of the spiritual significance of what you're doing when you're attending to the sick,
Mm.
being aware. And I would say that this is probably the most important thing, maybe that I'll say in the whole podcast. But when you're with a patient, being aware that you are not the cause of their healing. You are not um, the reason or the even just like the interventions that you're delivering. You're not the one who's in control of their health and their illness and their life and their death.
Mm.
Because that's the weight of the responsibility we put on ourselves when we accept all the secular materialist assumptions of the Western Academy and of medicine, modern medicine. So in Islamic psychology, we understand from obviously from our tradition, but also from all of its implications, that we are not the cause of healing. We hope to be the occasion of healing.
Mm.
We hope to be an instrument of that person's healing. But any change in that person and any healing they'll experience, it comes from a divine source of uh, infinite mercy. It comes from the one who created the very person who you're seeking to treat. It comes from that breath of mercy that had created everything in this universe. And so having a conviction in that completely changes how you interact with patients. It completely changes how you approach the clinical encounter. Even if at the end of my encounter with that person, I prescribe the exact same medication, it's still not the same encounter because I don't see myself as needing to be a fixer who's going to solve all this person's problems. Rather, I have enough humility to say, I don't know what's going to necessarily help them. I'm going to use every tool that Allah subhanahu wa ta'ala has given me to be of as much benefit to this person. But the outcome of that is going to be not in my hands.
Mm.
It's not, the outcome isn't mine to control.
I I I particularly appreciate, and I recently started to appreciate this aspect even more and more, how we decentralize ourselves from the whole process
Hmm.
of making sure that the patient gets somewhere,
Yeah.
because I think that's the whole pressure that we're also put in, that there is a healing that must happen, and it must happen through, you're gonna have to make that patient feel better.
Hmm.
And in most of the times that doesn't work this way. So just knowing that you're the tool, you're the way, but you're not the healer, and bringing it back to Allah.
Yeah.
And this is, I think, what I am really sitting with a lot in this training, is the bringing it back to Allah, of we're supporting the patient, or we're helping them be in a container where we could both be in the presence of Rabb al-Alameen
Hmm.
and witness um, the difficulty and the healing happening
Yeah.
at the same time.
Yeah.
So these should never be like, and I think there's this concept that, okay, maybe we should be healed at one point, but I don't think there's ever this place where we're okay, we're done, like like we're content. Or there could be places where we're maybe more happy with where we are,
Yeah.
but yeah, I don't know where my trail of thought went. But I want to know from you, as I think we're almost like wrapping up here, but I want to know from you, as someone who sees a lot of people who really are, mm, I mean, there's a range of mental illnesses, and I think working in a hospital particularly, you see more of the people who are actually really sick,
Yeah.
and who are needing a lot of support. Um, and did you feel like your support to yourself throughout this process also changed when you like kind of went into IP?
Yeah, absolutely.
Mm,
But not in the way that I think I or others would have anticipated.
mm,
What I mean by that is that I think, for example, someone might look at the training that you and I are doing right now, um, in an Islamic psychology based modality of psychotherapy. Where do we find ourselves? We're like in this beautiful farm that's on the beach with horses and farmland and an amazing view of the coast. And there's a sense and a very real and very important sense that the connectedness we feel with nature in this setting is part of what's therapeutic about some of these modalities, right?
mhm,
But to the onlooker, they look at this and they're like, well, of course you all feel really inspired and better because you're just in, it's like a really nice vacation. And there's a sense that our wellness is in our ability to attend some sort of retreats, to engage in, I don't know, yoga. And this is leaked all the way into the attitude even towards the wellness of medical students and residents.
Mm,
The committees who are responsible for ensuring the wellness of providers at the front lines of our public health system, they're well intentioned, but what are the things that they use to resource us is just allowing us to have massages and to pet dogs or to engage in yoga or to have fancy lattes,
mm,
basically to treat ourselves.
mm,
And obviously, there's a place for self care. There's a place for attending to your own body and your own wellness. But that's not the part of this training that affected my ability to care for myself in this training, or in the rigors of working in a hospital with severely ill patients. Actually, the thing that it I think protected me the most from um, was the moral injury that really most often actually produces burnout. It's
mm,
not always the acuity of how sick the patients are that I'm seeing. It's not always even um, the degree of volume, all the how many patients I have to see, how much paperwork I have to do. I think what is most uh, threatening to the wellness of a healthcare professional is when you start to lose a sense of meaning in your work because you start to view yourself as either helpless to really affect change in the problems that you just keep seeing come through your door, or worse than that, a cog in a wheel that is primarily turned by profit, right? That's primarily turned by a profit motive, which is a healthcare system that, just has its financial realities.
mm.
When you start to feel one of those two things, I think that's when you really start to burn out. And so Islamic psychology, I think, has allowed me to not only change the way that I view what I'm doing in the clinical space, but also to recognize that there is something indelibly unique about every provider and what they offer to each patient, including myself.
Mm.
Um, and again, almost none of the patients I see are Muslim. You
Oh,
know,
wow.
almost none of the patients I treat at the county hospital I work at are Muslims, and never is there any occasion that anyone has had to suggest that what I'm doing, that I consider Islamic psychology, is somehow denominationally specific or bringing religion into the hospital or something like that.
Mm,
And I think that's a big misconception. Um, Really, all it's done is, for me as a provider, to help me implement these convictions in a way that actually, by every measure that we use, has gotten better in terms of patient centered care, in
mm.
terms of really empathic understanding of my patients, in terms of, I think, just even the quality of me at the bedside.
Yeah.
That's really where this is influence. This is all of those things are metrics that I think that you would say have gotten better in the course of me being on this journey.
Mm.
The fact that they're rooted in sincere convictions that are based in the spiritual tradition I've never had a patient feel like there's something threatening about me doing something that
Mm.
is Islamic psychology, even with those patients with whom I've been very explicit.
Oh, wow. Lovely. Is there any, I know we're wrapping up.
Yeah.
Is there any, maybe not necessarily, not necessarily a successful case, but is there any case that you're thinking about or like a patient that you're thinking about on top of your mind that you feel benefited in one way or the other from specifically from this paradigm shift that you've had? Or like this doesn't need to be like something specific, but it could also be in general.
Yeah, I'm often careful with being too specific
Yeah.
because it's tough to, unless it's something I'm writing out, it's tough sometimes to anonymize things really
Yeah.
effectively.
Yeah.
I see a lot of patients, obviously. Um, I think there's a few cases that have been probably the most clear
Mm.
in my mind as ones that have benefited from this treatment approach. One is definitely patients with severe chronic pain.
Ah, wow.
Yeah, I think patients who experience daily chronic pain, first of all, it's one of those conditions that probably is. uh, the least well understood. We have the least developed, treatment modalities for just in conventional medicine. Um, Not because we don't have anything, but because it's even with all those treatments, these folks will often still be in pain in the same way that some of the chronic primary psychotic illnesses I treat, even with medicine, they'll still experience hallucinations, they'll still experience those things. So with chronic pain patients, it's similar. Like even with everything being effective in the treatment, whether it's medications, trigger point injections, these other things, multimodal, pain care, they still experience each day with just getting out of bed being a trial,
Mm,
with just doing the most basic things sometimes being a real test, a real difficulty.
mm,
Helping those folks, especially as a practitioner in a medical system that is doing everything we can to reduce their level of pain, helping them really accept the pain they experience, be seen as being in pain, and being present with what is
mm,
in that pain, despite it all. Those folks, I think, have often benefited the most from the psychotherapeutic techniques
mm.
that don't try to pretend like the only goal that is beneficial is to eliminate that pain, which often for them is an unrealistic expectation.
Oh, yeah. Or like kind of to reframe how you think about it, or like to reframe your thought because it's not about the thought, it's about like the actual experience of me
Yeah,
being in this.
yeah, helping them to really, I think, um, again, be witnessed as being in pain. That number one is something that they often don't have
Mm,
because there's nothing that we can measure that so clearly reflects how severe their pain is.
mm,
Often they're met with a lot of suspicion or a lot of
mm, mm, mm.
doubt or a lot of condescension when they
Yeah.
keep coming into our offices saying that they're in pain. Um, there is something therapeutic just in the process of hearing someone out with the pain and the distress that they're feeling.
Mm,
But then also, I think creating a container where it says, where my role is not just to fix them, but to have them just be with that pain, accept it for what it is, and at times realize the person that they've become, whether that's somebody who's extremely empathic towards others in difficulty, whether that's a person of extraordinary perseverance and persistence and courage, that none of that exists except in the presence of that same pain that they're experiencing.
mm,
Those
mhm.
realities exist simultaneously. That's part of why they are who they are.
Oh, wow.
It's not telling them that they shouldn't care that they're in pain or they should be grateful for the pain. It's two different things. But to accept the paradox that the thing that is the greatest source of distress in their life simultaneously is what cultivated their most admirable traits as a person, the things that actually give them the most pride about themselves, that those two things exist at the same time.
Mm.
And that's, again, I think that's all about accepting that the human experience is full of these contradictions,
Oh, wow.
and
Oh,
that's okay.
I think that's such a lovely note to end here. The accepting that the human experience is full of contradictions. And I'll just link it back by it's like it's almost confirmed that we're always full of contradictions and like the only truth is lying with especially with Allah. Like
Yeah,
that's the only big T that we know, and everything that's kind of underneath is always like, not sure. Is this that? I'm not sure. And having a place where you could lean on a truth with all of the contradictions, I feel like gives so much comfort and meaning to to your life. Mm. Ugh. I know we could like go on for another hour, but we're gonna wrap up here.
okay.
So Armand has a lot of like mashallah publications that I can like link some in the show notes, and maybe if somebody wants to reach out, we could link a handle, or not sure if you're on social media, but we could link whatever you feel you're comfortable in linking.
Yeah, I spend most of my time in the dark basements of hospital
Yeah.
of the hospital or the call room. So I don't do a lot of public facing social media things. Maybe that'll change in the future. I don't know. But
This is a start.
yeah, anyone who's interested in, most of my publications are in the area of public health.
Mm-hmm.
They're not necessarily on
Yeah.
psychotherapy in and of itself.
Mm-hmm.
But yeah, I'd be happy. But also just, I think folks interested in navigating um, the training, the rigorous,
Mm-hmm.
trials of training as a medical professional of any kind,
Mm-hmm.
especially as a person of faith or a person of religious conviction. Yeah, I'm happy to, for people to reach out to me about that.
Mm-hmm.
And we can just, uh, maybe just I'll commiserate with all the challenges that you're going to go through. I don't know that I'll give any good answers. Um,
You always have good answers. I think you're just undermining yourself. Okay, amazing. So inshallah, I'll link everything that's needed. And thank you so much again for your time,
of
for
course.
being here.
Thank you for having me.
Of course.